The following program has been made possible by an educational grant from Bayer Healthcare Pharmaceuticals, Inc.
Welcome. My name is Dr. George Kraft, and I'd like to welcome you to this 9th program in our series this year called Multiple Sclerosis from A to Z. In this series, we've covered a number of topics that are often not discussed, but really important for people with MS. We've covered topics on pain and fatigue, cognitive impairment, depression, obtaining jobs and keeping jobs, history of MS, overview of mechanisms, current thoughts about what this disease is. These are important topics, and those are programs that we have already broadcast. For those of you who may be looking for the first time to our program, I would call to your attention that you can see past programs on the web. If you go to uwtv.org, get the web page, and then in the search in the upper right-hand corner, type in MS from A to Z. It'll bring up past programs that you can look at. And for those of you who've seen previous programs, this is probably the one that you've most been looking forward to hearing. We're going to talk about new drug treatments for the disease, new medications to stop the disease of MS and slow it down and reduce its sequelae. And really, there's no one better to help us learn about these new medications than Dr. Erin Miller, who came all the way from New York to be with us today. Now, Dr. Miller is the medical director of the Corinne Goldsmith Dickinson MS Center at Mount Sinai Medical Center in the Upper East Side of Manhattan. He is also the chief medical officer of the National MS Society, the home office in New York. Dr. Miller, I want to welcome you to Seattle. Thank you for coming.
Well, thank you, Dr. Kraft. It's an honor to be the anchor, the guest for a wonderful series that you've had.
Thank you very much. We have a lot of items we want to discuss today, and I know that people would like to hear your comments about what do you think about any promising new drugs for MS?
Well, I think this is an incredibly optimistic time in the therapeutic arena for multiple sclerosis. I can remember the days when I was practicing, and I think you were too, when we didn't have any treatments at all for multiple sclerosis. And currently there are 6 FDA-approved drugs already on the market for the treatment of MS. The first one was licensed in 1993. But these drugs are only partially effective, and the 4 that we use as first-line treatments are all injectable treatments. So I remember for years people would say to me, "Doc, when are we going to have a treatment for MS?" And then starting in 1993, I could say, well, now we have a treatment that's at least partially effective. And no sooner did that drug get licensed than the questions changed to, "Doc, when are we going to have a pill?" And now, finally, I can say, well, we're going to have a pill very soon. And in fact, we may have a number of pills if the trials pan out all right. So right now, there are 5 oral agents, tablets, pills, capsules, that are either completed their phase 3 testing, the last stage in clinical trials before licensure, or have already been submitted to the FDA. And then we have some other very promising agents which are administered by intravenous infusion or injections, but are given extremely infrequently. So they too would offer big advantages over our current injectable therapies, which are given either daily or as infrequently as once a week, but require regular injections. So it's a really positive time.
You mentioned first-line treatments, and I think we need to probably explain what that means. Probably these are the first medicines you'd put somebody on when they're diagnosed.
there are no free rides in medicine. There are no medicines that don't have some kind of side effects. And whenever one treats a patient, it's really important to have a dialogue with the patient so the patient understands what are the potential risks of a treatment, what are the potential benefits. The 4 drugs that we consider first line in MS, which are the interferons, Avonex, Betaseron, Rebif, and the non-interferon Copaxone, are regarded as first-line agents because we know that they're extremely safe. We have 2 other drugs on the market currently, Tysabri and Novantrone, which are effective but have some significant risks to them. So those in general are used for patients who are not responding optimally or are not tolerating the first-line agents.
Do you think that these oral medications are going to be first line or not?
Well, I'm optimistic that one or more of them will become first-line agents. Not necessarily as soon as they're approved, because I think a certain amount of caution is indicated. The first oral drug that's going to be available is a drug called fingolimod, and will soon have a trade name, not yet officially divulged. But that drug is apparently extremely effective. It seems to reduce relapse rates to an extent when compared to placebo, which is a dummy medication, to a greater extent than we saw with the injectable drugs. Though I throw in the caveat here that you never really know that one drug is more effective than another drug unless you do a head-to-head comparison. But fingolimod has actually had a head-to-head comparison with at least one of the approved drugs, the once-a-week interferon Avonex, and it produced a reduction in the frequency of relapses that was quite as great as was seen with Avonex in that trial. So I think the drug's going to be effective, but it does have some side effects, and we know that when we do clinical trials, we take every possible precaution that we can take to assure the safety of patients in that trial. For example, every large trial has what's called a data safety and monitoring committee, which is a group of professionals who see all the information coming in from many centers. Often now these trials are done around the world with dozens and dozens of centers, and at no one center would you be able to pick up a serious risk. But these committees see all the data coming in. So the trials are conducted in as safe a fashion as possible. But nonetheless, when a drug comes to market, there haven't been tens of thousands of patients exposed to the drug. So we never can be completely confident of the safety of a drug until large numbers come on. So I think caution is prudent when a drug first comes on the market. But I think fingolimod has the definite potential to be a first-line agent. And even from the get-go, when the drug is first on the market, a dialogue between patient and doctor may allow that drug to be used as initial therapy even from the beginning.
When you see a patient in your practice, I know you have a busy practice, and I think it's a busy practice, feels very busy at times, feels busier than I would like at times. It's sometimes a challenge to know which medication to put somebody on, and it's something that I believe we have to do. We have to talk to the patient. It has to be something that they are comfortable with, and often patients have maybe been diagnosed elsewhere with MS, and they might come to me and for deciding what treatment to go on, and they may have some ideas, and I may have different ideas, and ultimately I agree with you. It's something that the physician has to discuss with the patient, and has to be something that the patient is very comfortable with.
It is a challenge, and it's going to be an even bigger challenge, and it's going to be a challenge that I suspect is going to be pushed more and more to MS specialty centers like yours and ours, because the general neurologist in practice, as we go from the 6 currently available drugs to potentially 10, 15 drugs over the next 3 or 4 years perhaps, it's going to be very difficult for the general neurologist first of all, to have all the knowledge that's necessary to sort among these medicines. And frankly, our healthcare system, unfortunately, doesn't allow the physician to have as much time as he needs with the patient. So I think we as MS specialists are going to be called more and more to help patients sort this out.
I completely agree. You mentioned that there may be 5 or more drugs coming up in the next several years. How many drugs are there in the pipelines? I mean, even beyond that.
Well, there are literally probably dozens of drugs in the pipeline. Remember, the pipelines are very, very long, and they're sort of like a funnel. Unfortunately, lots of ideas and drugs go in at the top, and only a tiny number actually make it out that little hole in the funnel at the end. And that's part of the reason why MS drugs and drugs in other areas cost so much money. Is you're not paying just for the development of that drug, but you have to cover the costs of all of the drugs that fail, which is not to excuse the enormously high costs of these drugs that patients have to bear or their insurance companies have to bear, but it does at least partially explain. It's not just that you're paying for that little pill that's in your bottle.
Yeah. Just out of curiosity, what do you think the cost of an average drug trial in MS is these days? How many millions and millions?
Well, I'd say for a phase 3 trial, which again is a trial that involves multiple centers, often now around the world, and many, many hundreds of patients, these typical large phase 3 MS trials are now running between 700 and 1,200 or even more patients, and they go on over several years. And $50 million is now probably a very conservative price tag for a trial like that.
Yeah, I think that's right. And I'm just sometimes concerned that we have maybe too many drugs chasing too few patients. Certainly in this country, we have, 400,000 MS patients, and certainly not all of those are appropriate for medications, maybe half or a little more than half. That's a lot of drugs for those patients.
Well, that's certainly true, and one would hope that as more competition comes to the market, maybe that will drive down the price of some of these drugs. So far, it hasn't happened that way, but then we haven't had that much competition yet.
Yeah, I want to interject something that we've been involved with from a research standpoint at the invitation of NIH, and that's to develop a better way of doing the clinical assessments that's much more sensitive, which would mean probably in tightly controlled group of patients, we could probably get more information a little faster with maybe some fewer numbers of subjects. And I think we're going to have to, as a society and as a profession, find more efficient ways to evaluate these new drugs, because it will be just phenomenally difficult. And as we have more and more patients on drugs, it's more and more difficult to compare the drugs.
Absolutely, and it used to be relatively easy to enroll patients in clinical trials and in placebo-controlled trials. When we didn't have any treatments that work, there was no ethical dilemma in putting a patient into a placebo or dummy medication trial. But now that we have drugs that are at least partially effective, it's no longer ethically justifiable to conduct placebo-controlled trials, which makes the designs of these trials much harder, and requires that more and more patients be included in the trials.
Yeah, I agree. I think it's a challenge to develop new drugs, and it is going to be more complex and more difficult. But I think it's very important because, as you initially said, we have medications that can control and reduce the severity and reduce the progression and reduce the relapses, but we don't have anything that really stops the disease cold in every patient.
Well, that's true, but I think, at least in terms of patients with relapsing remitting MS, which is marked by prominent inflammation, I think we're getting very, very close to really controlling the disease well. One of the drugs in its phase 2 trial reduced the relapse rate to 1 in 20 years, basically. And many of the drugs have gotten relapse rates down into the, under 0.3 relapses per year, which, is pretty good. And I think the future is likely to see not only that these drugs are more effective than our injectable drugs, but we'll probably ultimately start combining these drugs. We have to be sure that we're able to do that in a safe fashion, but I think that's going to be the case down the road.
Speaking of combining, I know that you've been involved with something called the CombiRx trial, and you want to comment on that? When is that going to be over?
Well, the CombiRx trial is really the baby of my colleague and friend, Dr. Fred Lublin at Mount Sinai, and that trial is fully enrolled, and I think in about another year and a half, I believe, if I'm correct, the code will be broken and the data analyzed.
What about the cost? Do you really think that the society and the new healthcare system think it can handle the cost of having somebody on 2 different drugs?
Well, it's very hard to put a price tag on good health and on something that's going to potentially keep an individual from being unable to walk, unable to think normally, unable to control bladder, bowel, and sexual function, able to work and live through the day without the significant fatigue that MS often causes. So it's really a tough question to answer. I think the insurance companies, of course, will be very cautious about what they're willing to pay for. I think they'll want to make sure that treatment trials in an individual patient have been optimized at a single drug before they'll allow combination therapy. But I don't really think ultimately they'll block the use of multiple drugs if that's what it takes to control someone's disease.
And I think at present, at least, they really cannot not cover a drug that's been proven to work in well-selected patients. It's the off-label use. You might comment on off-label use, if you will, but I think it's the off-label use that has been a real problem with some of the drugs being covered.
Yeah, I think for our audience, what we mean by off-label use is the use of any drug that is a drug that is legally on the market, that has been FDA approved for use in some circumstance, but the doctor prescribes it for a circumstance that's not in the approved FDA labeling. So, for example, sticking with MS, all of our current drugs and the ones that are in the immediate pipeline are either already approved or are going to be approved for use in people with relapsing forms of multiple sclerosis. So some physicians will prescribe these drugs for people with progressive disease, either primary progressive disease or secondary progressive disease without relapses, and that would be regarded as off-label use.
If a patient of yours is on an injectable and they're doing really very well, and they come to you and they say, Dr. Miller, I'm just tired of injecting myself. I think that's a bit of a dilemma because the longer the existing drugs have been on the market and basically they're very safe, almost all of them very safe, and we don't know the future for some of the new medications. How do you think you're going to handle that?
Well, I've given a lot of thought to that because, I have many patients on these injectable drugs, and many of them are doing quite well, at least from my perspective as a neurologist. But I don't live with the daily or thrice weekly or whatever is the regimen. I don't live with those injections. And I'm sure that you've seen, as I have, that patients who've been on these drugs for years have increasing difficulty with the actual physical mechanics of doing the injections. The tissue becomes hard, it becomes difficult to do the injection. In some cases there's loss of subcutaneous tissue and it becomes cosmetically unpleasant. So there is a big desire of patients, even those who are doing neurologically well, to get on oral medication. I'm a pretty conservative adapter of new medications, adopter, I should say, of new medications. And I'm going to have a frank conversation with the patient. So, for example, with regard to fingolimod, which will be the first oral drug on the market, I've already had this conversation in advance with a number of patients, and I've said, look, this is a very, very promising agent. It has some side effects. Why don't we wait over the next 6 or 12 months after the drug is on the market as larger numbers of people get on so that we can get a better handle on the safety profile. On the other hand, if a patient says to me, look, doc, I understand what you're saying. I understand the risks because I will have told them in detail what they are as we know them now. if he or she says to me, I understand that, but I'm miserable taking these drugs, I really want to give it a shot or give up my shots, I'm probably going to prescribe that oral medication.
I think I completely agree with everything you say, and I've also had these conversations with my patients, and have many patients that have been on injectables since really late in 1993, and it's a challenge because they have really a lot of changes in the skin, and it'd be very difficult. I certainly think that it's nice to have some options that are not injectables, and look promisingly effective and seemingly reasonably safe.
And I think there are a couple of the oral drugs that are still maybe another year and a half, 2 years away from reaching the market, assuming their phase 3 trials are successful, that might be that might look quite safe based on what we've seen in the phase 2 trials. And those might be an option. Maybe they'll be a little less effective than some of the other oral agents that have more side effects. And then there's going to be a balance. So I can see, for example, if one of these drugs, perhaps fumarate, which is also known as BG12, or laquinimode, or teriflunomide, one of those agents might come in with fewer side effects and a lesser, what seems to be a little bit less effectiveness, but maybe you put the patient on that drug from the get-go and see how they do. If they're doing well, if there's no breakthrough disease, then fine. If they break through, you've got bigger guns.
Are there any other promising treatments other than the new pills?
Well, there are a number of agents that are given either by infusion or by injection, but they're given infrequently. Right now, as you know, we have one drug that's fairly widely used as an infusion called Tysabri. And that drug is reserved generally for people who are not doing as well as we'd like on the injectable drugs, because it's been associated with a rare but very serious brain infection called PML, or progressive multifocal leukoencephalopathy. And that infusion is given once every 4 weeks, so that's relatively infrequent. But we now have one drug that's being tested that's given for several days in a row, and then no more treatments for a year, a drug called alemtuzumab, or Campath. So that's a very attractive regimen for a patient. Get it all done with and then forget about things for a year. That is a drug that has some potentially serious side effects. So I frankly don't think that that's going to become a first-line drug. But that's one agent. There are several other injectable or infused agents that are in the pipeline in advanced testing that are given not quite that infrequently, but also very infrequently. There was a drug called rituximab that had a positive phase 2 trial. That's a drug, that's an antibody directed against a kind of lymphocyte called B lymphocytes. Rituximab has been and that drug, by the way, is on the market for rheumatoid arthritis as well as some other conditions. That drug has been shelved in terms of its development for MS to be replaced by a very closely related drug called ocrelizumab, which has some advantages over rituximab. That drug has now had a positive phase 2 trial and will be going very soon, I expect, into phase 3 trial. And that's a drug that's also given quite infrequently. Another drug called daclizumab is given by injection under the skin, and that's also given infrequently. So there are a number of agents besides the oral drugs which don't have the appeal of being a pill, but have the attraction of being given very infrequently.
I want to go back to ask you about something you said earlier, and that is you mentioned that these were all these drugs that we have now, and the ones that are likely coming on the market soon are for relapsing forms of MS. It leaves us with about 15% or so of the population of MS people with what we call primary progressive MS, or an MS that doesn't have the ups and downs of the relapses and remissions. Several drugs have been tried, including rituximab and Copaxone, and really didn't show that they would work. Are there any promising things on the horizon for that category of patients?
Well, you know, this for those of us who struggle every day taking care of people with MS, one of the huge disappointments for us is to confront patients with progressive disease, particularly primary progressive patients, but also secondary progressive patients, and say to them as their condition deteriorates, we just don't have a treatment that's been shown to slow the progression of your disease. And there's been an understandable reluctance, I think, of the pharmaceutical companies to test drugs in these areas because so many of the trials have been negative. And as you mentioned before, the costs of doing these trials are so enormous that the temptation is clear to go for a winner. But nonetheless, I have a certain amount of cautious optimism in the progressive arena. Fingolimod, the drug that's about to be marketed, is being tested in the primary progressive population. Primary progressive MS, for our audience, are people who never have relapses or attacks, but instead get little by little worse over the years. Fingolimod is now being tested for primary progressive disease, and even though that's been a population that's been a very tough nut to crack, I have a sneaky suspicion that this is going to be a positive trial. And the end of this trial is several years down the road, at least 2 years down the road, but we'll see.
Well, I think that that is a group of patients that we really, excuse me, really don't have a good handle on, and all of us who take care of those patients would like to have something we could offer them.
I think it's important to emphasize that, a long time ago, an early mentor of mine, Dr. Leib Scheinberg, who is regarded as the father of comprehensive MS care. I had the privilege of working in his clinic when I was in training, and I remember his always saying that there was always something you could do for a patient with MS, even before we had any drugs that impacted the natural course of the disease. And people with MS have many, many symptoms, and there are a lot of ways that we can help with those problems, even if we're not controlling the disease. And there recently, for example, has been approved a drug that helps the walking in some people with MS, a drug called Ampera. And that was tested in a trial that was aimed at improving walking speed. But walking speed is a proxy for other aspects of walking. And the people in that trial who did improve in their walking speed also endorsed benefit on a number of other aspects of walking. Now that's a pill. It's taken every 12 hours. It doesn't work for everybody, but in the clinical trials it had a significant benefit in about 40% of patients who took it. So that's one aspect. Of course, you know better than anybody else, because you're a physiatrist, that physical medicine and rehabilitation are critically important in maintaining and improving the function of people with MS, particularly with motor disorders, but also with other aspects of their disease. There are other symptomatic treatments that are on the market, and we have ways, for example, to improve the bladder function in people with MS. That's a very common problem with people with MS. We have ways to help the sexual function, at least in men with erectile dysfunction in MS. So there are many symptoms that can respond in some cases to medicine, in other cases to physical treatments, and we can help these people lead better lives.
I'm really glad to hear you mention Leib Scheinberg's name, because he brought me into the field of MS. He said this was really before we had anything else to offer patients. He says, you've got to get involved and take care of these patients. And if my life has changed and hasn't been the same since. So let's talk about other theories and maybe other ways to treat this disease that are not really immunologic based. There's a surgeon in Italy who has developed a procedure in which he says that by opening up the venous outflow from the brain, he feels he can help people with MS. So there are a lot of people that many have gone to Europe to have this procedure. Can you comment on that? Tell us the rationale and what you know about it.
So this is a theory, and at the moment, really, I think it's best to regard it as a theory. That's been promulgated by Professor Paolo Zamboni from Italy. And what he defined an entity that he calls chronic cerebrospinal venous insufficiency, or CCSVI for short, and that's how I'll refer to it. And his work was based solely on investigation of patients with a technique known as ultrasound. And what he found, what he claims to have found, was that patients with multiple sclerosis, based on this ultrasound technique, seem to have blockage in the drainage of the veins from the brain or from the spinal cord. And he defined the syndrome based solely on his observations in this ultrasound technique. It's important to emphasize that in all of the medical literature prior to Professor Zamboni's work, there was no evidence of this condition, CCSVI, in multiple sclerosis. Now, we can absolutely understand and empathize with people who have MS and see the attraction of an easy fix. I mean, we've been giving medicines now for many, many years. We help a lot of people, but we certainly don't cure the disease, and we don't control the disease completely in a lot of people. So there's a natural attraction to the thought that you can go in one time, open up blocked veins, and stop MS. But we have to be very, very careful about this. And in a sense, I think the situation has been kind of the perfect storm for medical controversy. We have a situation in which there's the natural attraction of the desire for a quick fix of a serious condition, a publication that came out in a respected peer-reviewed journal by a professor of medicine, a situation that's unfortunately been inflamed by the mainstream media, who have not really responsibly addressed the issue. The use of a term, Dr. Zamboni has coined the term the liberation procedure, which is a kind of a politically charged term. And on top of that, his wife suffers from MS, and he says he's helped his wife with this. So we have all things kind of coalescing together, I think, to raise the threshold about this beyond where it ought to be at this time. This is a theory, and it needs proper scientific address in the research community. And that's being undertaken under the aegis of the National MS Society in the United States, the MS Society of Canada, the MS Society in Italy. A number of well-designed research studies have been funded now to try, first of all, to reproduce Zamboni's work. Because the first question is, were his observations valid? There are a number of technical issues in the reports of his work. For example, ultrasound techniques are very subject to operator influences, and these studies were not blinded. That is, the people performing the ultrasound tests knew that these were people with MS. And frankly, Dr. Zamboni's initial report that said that this condition, CCSVI, was present in 100% of people with multiple sclerosis and 0% of the people he studied without MS, is biologically something that we never see in medicine. Nothing is all or none in medicine. And subsequent to Zamboni's reports, there has been a study in Buffalo that showed in their hands that 56% of people with MS had the condition, but 45% of people with other diseases had the condition, and 23% or so of controls, healthy controls, had the condition. In addition, in the past month or so, we've seen the publication of 2 other studies from Europe that have not found any relationship or any difference between MS patients and controls. So the first question we have to answer before we jump in and do therapeutic procedures is this a real valid observation? If it is a valid observation, then the next question is this something that is causative, or is this just an association? It could, for example, just as easily, if it's true, be a result of MS as it is a cause of MS. But the way you answer that question is you do a properly designed therapeutic trial. After you've established that there is an association, then you go in and you do a trial in which some patients have the procedure and some patients have a sham procedure. For example, the treatment that would occur would be what's called a venous angioplasty. So you could go in with a balloon and open these veins, presumably. And the control, for example, the sham procedure might be to pass the catheter in and not inflate the balloon. And that way you can answer the question, is there a therapeutic benefit to this? There's too great a placebo response in every MS clinical trial. So you can never reach a conclusion that a treatment works unless you have some kind of proper control group.
Yes, and it's also interesting, I think, that he found none of the primary progressive MS patients had this. 100% of the relapsing remitting patients had this.
And it is important also to note that Professor Zamboni did report one small open label trial of his procedure, and even Professor Zamboni noted no improvement in the patients with progressive or advanced disease.
But it opens questions about the technique of treatment, and assuming that it is indeed causative, and I don't believe it is, but supposing it is, the treatment is very, very difficult because you generally have procedures in the heart and other parts of the body where you can work on arteries to open them up. Put stents in, and with a venous drainage, it's a bag, it's a sac, and if it's not being filled with blood, it's going to tighten down. And putting stents in, as you probably know, has come up with some really unfortunate results. They migrate to the heart and so forth. So it's not technically an easy job. In fact, I think Dr. Zamboni has said that he's gone, I believe even his wife was operated on more than once.
Right,
It
and
doesn't stay that way.
I think in his study, 47% of the people that underwent angioplasties, venous angioplasties, reclotted or re-occluded their veins in his term. And I've already seen one of my own patients who went for this procedure in Brooklyn, not at my recommendation, by the way.
It's closer than Italy. No,
and she clotted off her jugular vein, and she had to go back in for a procedure to try to lyse the clot. The next day, it lysed the clot. The following day, it clotted again, and she ended up on blood thinners for 3 months. And being on blood thinners, as you know, has its own risks. At Stanford, a stent was used early on in this controversial treatment paradigm, and there was a death from a brain hemorrhage, and there was a second stent that migrated into the heart, as you alluded to. So I think it's very important. I personally think it's very important that we go through with this research to establish whether or not there really is an association. We've scoffed at a lot of ideas in medicine, and a lot of the ideas we've scoffed at were worth scoffing at. But every once in a while, something pans out. The analogy I think we often make is the identification of a bacteria as the cause of peptic ulcer disease. When you and I were in medical school, I'm sure we were taught that it was stress and it was type A personalities that led you to have peptic ulcer disease and perhaps bleeding ulcers. And now we know it's a bacteria that's responsible. We would have laughed at that.
Yeah, you're absolutely right. As the Chief Medical Officer of the MS Society, would you want to comment on ways in which the MS Society is helping get at some answers to things like the Zamboni procedure?
Yeah, I think, as I said before, the National MS Society, as well as the Canadian MS Society, jointly have gotten together to fund research projects on CCSVI. And the National MS Society is very sensitive to the needs of people with MS and is committed to putting research dollars behind any promising idea that might lead to improvement in the lives of people with MS and ultimately to a cure for MS. But of course, this has to be done in a scientifically rigorous manner. So what the two societies did a number of months ago was they put out a request for proposals to study this issue. many proposals from around the world came forward, and an international panel was convened. I had the privilege of participating in that panel. The panel included people from many relevant disciplines: neurologists, neurologists with expertise in neuroimaging and MRI, vascular surgeons, interventional radiologists, statisticians. So a whole group of people that would bring different viewpoints to the table. And they assessed all of these proposals in what we regard as the traditional scientific peer review process, and what were regarded as the best 7 of these studies were funded. And the funding has already begun, and the work has already begun several months ago. So I think we're going to get an answer. I realize the answer might not be as quick as some people would like it to be. Science needs to go at its own pace. You can speed it up to some extent, but you have to do it responsibly.
And that's another argument to favor the support of a really excellent organization, the National MS Society. So we might segue now into stem cells, since we're talking about more controversial things. There are adult stem cells that can be used in a certain way, and fetal stem cells that can work in a different way. Can you comment on those?
Yeah, so, I'm not, of course, myself an expert in stem cell biology, but the idea of stem cells has certainly, as a therapy for MS as well as for a number of other diseases, has certainly captured the fancy of patients as well as of biologists and clinicians. But I think it's kind of naive, the idea that most patients have about how stem cells would work in MS. And their idea is that, let me just back up a little to remind people that stem cells are cells that have the potential they're primitive cells that have the potential to develop into many other different types of cells. And what's called a totipotent stem cell has the potential to develop into any other kind of cell in the body. And so the idea that people sort of cotton onto is that, well, you give these cells and they go and replace the oligodendrocytes, which are the cells that make myelin, which is in turn one of the key damages in MS. Well, that's probably a naive idea. And in MS wouldn't be the most logical disease to try to use stem cells in to replace the cells of damage, because the damage is kind of random in MS. And so there would be many issues in getting a stem cell to replace the kinds of cells that are damaged. First of all, you'd have to get the cells to go to the target. You have to instruct them to differentiate into the kind of cell you want to replace, oligodendrocytes, for example, in this case, and not go on to make some other kind of cell that you don't want, and in particular, not to make tumor cells. So there's a lot to that idea. But it turns out that there are other potentials for stem cells, and they may be very important in regulating the immune system or in regulating repair of the nervous system that doesn't require them to actually differentiate into the precise damaged cell. The other thing is that of course, the situation with stem cell research in the United States, at least, has been clouded by the understandable controversy about the use of fetal stem cells or embryonic stem cells. And on whatever side one is on in that moral and religious and philosophical controversy, I think we all would feel that we would love to have a way to be able to look at stem cells without using embryos. And I think tremendous progress is being made in that area. So a number of studies are now looking at what are called mesenchymal stem cells, which are stem cells which don't have quite the capacity to develop into every kind of cell in the body, but do have the capacity to develop into the kinds of cells that we in the area of MS are interested in. And we're already seeing mesenchymal stem cells moving into the arena of some very early clinical trials. I want to emphasize that these are very early clinical trials, and this is not ready for mainstream treatment. And I really want to caution patients about this phenomenon that's gotten the term medical tourism. And this applies both, for example, to stem cell therapy and particularly to CCSVI that we were talking about a few moments ago. If you go and Google CCSVI, for example, up will come sites inviting you to go to Romania and Poland and Kuwait and India and Costa Rica for these procedures. And similarly, there are clinics around the world that are promising to do stem cell transplantations for people with MS. These are centers often that don't have any legitimate expertise or fundamental biological knowledge of the disease and how stem cells would work. And I think patients need to follow the recommendations of their well-trained physicians and converse with them and get themselves well informed rather than going off to places where one's safety, medically speaking, is really in doubt.
I think there is another type of stem cell, though, that is what is being used in this country, and that is the adult stem cell. And we've been involved with that here in Seattle since 1999, in which we can harvest a patient's circulating stem cells, cryopreserve them, and then use really large doses of immunosuppression to help at least convert the disease into something a little more quiescent. And then we really need to get the stem cells back because they need to form a new blood system. That is really, I think, something like 200 people in the world now have been treated with that, and I think about half of those in the United States. Something that we've had some success with, and I think that is something that people use the term stem cell, but that is a technique that is legitimate and being done very cautiously still under research protocols.
Right, I agree with you. I think there are some very responsible clinical trials being done both here and in Canada, for example, with Dr. Mark Friedman. I regard those treatments as really not exactly akin to the kind of stem cell treatments that most of the public thinks about. I really think that the key to that type of stem cell transplantation is that you are blasting the immune system, that you are basically required for that kind of therapy to obliterate an MS patient's immune system and basically reboot. It's like rebooting your computer in the hopes that trouble won't happen.
Beautiful analogy, I like that. I'll quote you on that one.
And of course, as you know, there are serious potential risks in eliminating a person's immune system for a period of time while you wait for that replenishment. Also, although so far these hematopoietic stem cell transplants have appeared to work in some patients for a period of time, a lot of patients, by my understanding, have escaped after several years. So I think this is a niche therapy at the moment, needs some more exploration, but I don't frankly think it's going to be an ultimately widely used form of therapy.
I think the other advantage is it is research, and it will tell us more about the disease, and we will learn more about the disease by doing procedures such as this. Yes. And sort of an overview of patient management and the use of medications in MS. I think all of us in practice have seen patients who don't seem to respond to one particular medication, and then we change class or something, and they do a little better. It seems to me that with these new medications coming on the market, we're going to have more options to try different things, and be a whole series of things can be tried. But I think that there have been some attempts, and I'm not sure how successful they've been. I don't think they've been terribly successful, but you might want to comment on them, to determine in some sort of a more scientific way what patients are going to respond to what medications.
Well, first of all, before I actually answer that part of your question, Dr. Kraft, I think I've had a particular interest in the question of prognosis in multiple sclerosis. And as we have more and more choices of therapies, some of which are a lot riskier than others, it would be really helpful for us to know early on in the course of the disease who's destined to have a lot of problems with their MS and who, on the other hand, may be destined to have what we refer to as benign MS,
which isn't benign.
Which at the present time is something we can't really say till 20 or 30 years after a person's had the illness. And I think we've tended as physicians to sort of just throw up our hands and say to a patient early on, MS is an extremely variable disease. You know, some people do well, but a lot of people have problems, and we have no way to tell at this stage how it's going to be. I think we're actually gaining information that give us good clues. Not that we're going to be right every time, but every decision we make in medicine is based on statistical probabilities when we assess the risks and benefits. And I think we can early on look at patients now and say the likelihood that you're going to have a difficult course with MS is high versus somebody else who looks much less. For example, there are a number of clinical clues. We know that a person who has motor deficits in the initial attacks is likely to have more problems than a person whose symptoms are all sensory. A person who's had a short period between their first two attacks is likelier to have a worse prognosis than somebody who's gone a number of years between the first two attacks. The person who has residual neurological deficit after the first attack is more likely to have problems down the road than the person who makes a complete recovery from that initial attack. A person who has bladder symptomatology in the early attack is likely to have more problems. So that's just looking at the clinical clues. We know now that a person whom we first see that has a very large amount of MRI, of disease activity on the MRI, is likely to do worse. So I think when we can start to profile patients, and while we will make mistakes, I think we at least have a sense of in whom we might really want to get out the big guns early and whom we might want to hold off. Now, with regard to your specific question, one of the interests is in an area known as pharmacogenomics. And this is an area where, and this is very, very early work in the MS arena, as well as in most other areas of medicine, but one is going to be able to start to look at the gene profile of specific patients and be able to identify whether a patient is more or less likely to respond to a particular class of medication. For the moment, most of the work in MS, and even this has been relatively meager so far, has been with regard to the use of interferons as therapy. But there are some early studies that have suggested that certain gene profiles might indicate a patient who's more likely to respond to therapy. And I think we'll be seeing more and more of this so-called personalized medicine as we go down the road in the next decade.
And it may well be that different types of profiles respond to different mechanisms.
Absolutely.
So if you wanted to put on your sort of prognosticator hat again, would you want to offer any thoughts as to timing on when some of these new medications, you mentioned FTY-720 or fingolimod would be the first one out, and that should be maybe the end of 2010 or so?
Well, fingolimod has a September 21st date with the FDA, so that's the date by which they've promised to make a decision. Another drug has already been accepted for review by the FDA, a drug known as cladribine, which we haven't talked about.
Oral cladribine.
Oral cladribine is a potent immunosuppressive agent, which is also taken for a few days for several months, and then you're off for a year again, then you take it for a few days once a month for several more months. So again, a very long-acting drug. So that's under review by the FDA. So we probably expect a decision on that drug within the next relatively short time, a matter of months. The other oral agents will all be probably completing their phase 3 trials in late 2011 to early 2012. So not very far off should we start to see the fruits of these clinical trials, and I hope they'll be ripe, delicious fruits.
And don't we all? Well, we're winding down our hour. We have just a little bit of time left. Would you like to give us an overview of, I think you probably have, and maybe kind of summarize your overview as to new medications in MS, just things that people can just remember?
Well, I think as we get hopefully many, many more agents on the market, I think we're going to be trying to tailor a therapy for an individual patient. We're going to be assessing that patient's, as I said, what looks to be their disease profile. And this is a dynamic field, so we're learning more and more as time goes on, and I think we'll learn more about ways that we might predict the future. We need a biomarker, for example. That's something that we can measure in a body fluid, in the blood or the urine or the spinal fluid, that is predictive of what the future is going to be. And there's some tentative suggestions that there might be some candidates for that. So I think we're going to tailor the medicine not only to the type of disease the patient's likely to have, but then we're going to have tailor it to the individual's tolerance for risk versus tolerance for unpleasantnesses of treatment, injections versus oral agents. Do they want to take a chance and sort of go for broke up front and get out the heavy ammunition and start on a drug that really seems to be very potent but has some risks? Or do they want to start on a drug that has fewer risks but may not be as effective? So there are going to be a lot of options, lots of interesting conversations that I'm looking forward to with my patients.
Well, I'm sure your patients are very, very fortunate to have you as their doctor, because clearly you care about them, and I know I know some of the patients that you have, and they do like you a lot, so I can understand that.
Well, thank you.
So Dr. Miller, I want to thank you very much for coming to Seattle to tape this. I hope this will be useful to people who have seen this show, and I want to comment again that if you put uwtv.org into your computer and click on the MS Made to Z in the upper right-hand corner, you can open previous programs we've had in this series. There are a total of 9 programs in this series, and this is the concluding program number 9. And for this program, I again want to thank Dr. Aaron Miller, who is the Chief Medical Officer of the National MS Society in New York, for coming to Seattle and joining us today. Thank you very much.
Well, thank you. It's been a privilege.